for our educational program entitled Dr. ChatGPT Will See You Now, presented by Kimberly Lomis. Dr. Lomis is the Vice President for Medical Education Innovations at the American Medical Association. In that capacity, she guides the AMA Change Med Ed initiative, partnering with medical schools and GME programs to impact over 30,000 medical trainees across the United States. Themes of collaborative work and advocacy efforts among the institutions of consortium include competency-based medical education, training in health systems science across the continuum, value-added roles for learners, development of master adaptive learners, coaching for health professionals, promoting diversity of the physician workforce and inclusive environments, addressing learner and faculty well-being, advancing educational technology, and change management. Dr. Lomis previously served as professor of surgery and associate dean for undergraduate medical education at Vanderbilt University School of Medicine. Dr. Lomis received her BS from the University of Texas at Austin in 1988 and her MD from the University of Texas Southwestern Medical School in 1992 and practiced general surgery until 2012. Please be reminded that this presentation is being recorded. If you have questions, please put those in the chat. Thank you for joining us again, Dr. Lomis. Please take it away.
Well, thank you, Dr. Marshall, for that invitation, and thanks to all of you for inviting me to join you tonight. And thank you from the AMA for being engaged the way you are in your medical society. I know after a long day of work that it's tough to sit through a meeting and a talk, and so I'm glad to see the collegiality that you all have together to continue forth with the advocacy mission that you have before you. And to just orient you to where I sit within the AMA, you're very familiar with the House of Delegates process, since that aligns with the work that you do. I'm on the mission side, and so once the House of Delegates has established policy, that transfers over to a leadership team to execute. And so we have a lot of policy around the space of medical education and, of course, around artificial intelligence, which will be our topic for tonight. And I'm in a unit who helps to implement those things and really affect the change that our members are calling for. So hopefully that helps orient a little bit of how I fit into the AMA and how you might connect with what we do. So I'm not going to dwell specifically on ChatGPT. I hope that's not too disappointing to anyone. But I am going to talk about more broadly how artificial intelligence is changing both healthcare delivery and medical education specifically, which is my area of expertise. And I do hope that this will be a conversation. So please use the chat, and I'm playing with my screens right now to make sure I can still see it. Use chat functions and leave comments throughout, and please don't hesitate even to raise questions. We're a small group, relatively small group, so raise your hands and ask questions, and I'll ask my colleagues on the call to help me watch for all that. So thinking broadly, again, as I said, about how we're incorporating artificial intelligence into medical education. So as a disclosure, I've shared that I am an employee of the AMA. When we present, we're reminded to state that we do not necessarily always represent AMA policy, although I am consistent with it in this talk. Most of the resources I'm going to share refer to our open access that have been developed by the AMA. In the MedEd team, the few things that we have that are commercial products go back to funding our initiatives in medical education. So hopefully that is not of any concern to everyone. And then I think the other thing to recognize is I'll mention that this is work that's emerged out of the Accelerating Change in Medical Education, or Change MedEd initiative, but it's also informed by work that I've been doing with the National Academy. So there is a spinoff of the National Academy of Medicine that is really looking at innovation across professions education. And so that group has been active in this space as well. And then the final disclosure is that I am not a computer scientist. I am an educator. And so I am going to be speaking more from that perspective. So not so much about, I'm not an AI guru. As a matter of fact, my son, who is an aerospace engineer, is appalled that I do all these talks about AI. But really, I'm a champion to say we need to be thinking about this together as a profession so that we don't get caught off guard. So I applaud you for inviting us to have this conversation tonight. So just a little fun in the chat to get us warmed up. You know, if people want to put your immediate reactions when you hear the terms artificial intelligence, or you think about the relationship to your practice, go ahead and pop into the chat, just things that come to mind when you hear these terms. Terminator versus exciting. And I think that's a great juxtaposition of those comments. So there is tremendous opportunity, and will hopefully generate a lot of that thought about excitement. But there are some appropriate cautions. And so we'll talk about that kind of balance of the promise and the peril as we embark into this space. So again, just to remind you where we are anchored in the history of the AMA regarding medical education, we certainly have a very long history looking at continuing professional development, but had not been all that active at the level of med schools until 2013, when the Accelerating Change in Medical Education initiative was launched. And that call brought together many medical schools. Initially, 11 got grants, but it grew and grew and grew and really created a community of innovation. So it's a very dynamic group that shares ideas and really shares struggles as much as successes, which is unusual for many of you who are used to that academic environment where we just share everything that went so well. And so this group has been very active in innovation, and some of the work that we're discussing emerges from that. We have since expanded from medical school to residency training, and the residents are very active in this space of AI. So if we look back at our history as physicians, there was a period in which we didn't really have a lot that we could do in terms of intervention. We were there, we were observing, we were learning. And then, of course, we have since then changed dramatically in terms of what we can do in our interventions. But many of you recognize that the education itself didn't really change too much over about a 100-year period. And so part of what we're doing is disrupting not just the content, which is something we'll talk about tonight, but really thinking differently about the process of education. So we'll address that as well. And so we've moved students out of lecture halls to do much more active learning techniques. And we have students engaged in meaningful clinical roles much earlier in their training than when I went through training in the Stone Age, as you heard my background bio. So we're changing up the structure and the process and the flow as much as the content. Because the practice of medicine evolves so quickly, we need to have learners who are able to adapt more readily as well. And so you heard us refer to this notion of the master adaptive learner. The other model that's very important to us is health system science. And listening to some of the struggles that you were talking about in your opening comments around some of the ways systems financing is impeding your ability to deliver the care that you want, I would refer you to these resources. Many of us who are in practice never had formal training in health system science. And so learning even just the vocabulary of how to express a concern about the system or to whom you might take it is quite valuable. There's a full textbook. Nobody likes to read books anymore. There's online modules that you'll see them, they're geared for students, but they're really appropriate if you've never had any explicit training in these topics of how to manipulate the system and how to work with it for improvement. I'd encourage you to check them out. But within this model, as you see, health informatics and health technology is one of the critical elements of the system. And I think all of you are aware that artificial intelligence is dramatically changing practice already and will continue to do so. And so have we changed the way we think about education sufficiently to account for the changes in the information that surrounds us? My dad was a primary care doc in rural Pennsylvania, not far from where many of you are. And really back then, pre-internet, if he didn't hold something in his head, his patients didn't have access to that knowledge, right? It was as simple as that. But now in reality, there's most of what we need in terms of quick fact checks right here on our phones. And so rather than continuing to focus on students mastering a body of content, and rather than schools thinking about covering everything, we really need to shift and train physicians to how to think critically, how to appraise the information that's available to them, how to access it and apply it to individual patients. And so it requires us taking some things out of training, less memorization, less factual basis, and substituting instead more training on how to continue to learn. Now, this isn't entirely popular with students who think of themselves as pretty advanced learners, right? Just to get into medical school, you're considered a good student. But that's in a very structured way. And all of we've been on the ground with you. It's really hard to keep up. You might have the best intentions of keeping up with your journals and try to set aside time, but that time quickly gets eaten up by documenting clinic notes or other things. And so we've found that a lot of physicians have a degree of moral distress around their inability to devote as much time to their education as they feel they need to. And so we're really working on that. And we have other projects that I'll mention towards the end of this talk to try to help with that. But I think this really reminds us that even in our health systems, we need to elevate the value for continued learning and critical appraisal so that the physician can serve that role for patients and for communities. So we have a slide in this talk that we give this talk to a lot of different audiences, often not physicians in practice. And so before I put up what physicians are feeling today, I actually thought I should pause and allow you to pop into the chat. What are you feeling today? This is my chance to hear directly from you. And so I heard you're quite tired. Someone was very fast on their typing for that. Share anything that you're experiencing. It's really important for us at the AMA to understand. So clicking, yes, the documentation, right? And that has gotten more and more excessive. Anyone else want to share some of the frustration that you're feeling or challenges that you face in your day-to-day? Stretched, clictation, perfect. And then we have some hopeful. Great. Well, thank you for sharing, and you can continue to put things in there because we'll pay attention to this. Alarm fatigue is definitely a real thing. So this is fairly consistent to what we think you're feeling. So the AMA, as you know, does a variety of studies to look at how physicians are doing. It's obviously our core mission. And all of you are feeling some strain, hopefully not full out burnout, but definitely I'm seeing in the chat those challenges that push you that way. And we do look very closely at the time that you're spending and how you're spending it. And the increasing burden of documentation is very much on our radar. Tips of how to avoid what we call pajama time, sitting at home at night in your pajamas, catching up on those notes after you've gotten everything else for your household done. And so if you need any help with that, I would refer you to Steps Forward on the AMA website, which is put together by our PS2 team, the Practice Sustainability and Physician Satisfaction team, who have some really good pragmatic tips about how to manage those tasks for yourself. But this is one area where AI offers us tremendous potential, and we'll come back to that. But if we can offload these rote tasks to allow you as physicians to spend more time with your patients, which is the thing that we all find so rewarding, then that's going to be a big win. So that's one of the potential advantages. And I have a note here. We have a recent study through our Reimagining Residency project that shows that a real-time motion study of residents who agreed to wear badges so we can tell exactly where they are, show that they spend less than 15% of their time directly with patients. And much of their time is in the workroom, as you would imagine. And so that is certainly fueling this concern around burnout. At the same time, patients and communities feel lost. The system is very convoluted. They struggle to understand how to navigate through everything that's out there and how to get the care that they need. And so how could we use technology to address some of these challenges? One of the reasons we're having some challenge, I really like this book if folks haven't seen this, with Thomas Friedman. I was looking into why we see such an increasing amount of anxiety in our incoming medical students. So we know medical school is stressful, but the incoming students more and more are reporting anxiety walking in the door. And Thomas Friedman's book talks about this general angst in our entire society right now that has to do with rapidly increasing changes in technology and climate change, and this overwhelming sense of information that we have, and that we are exceeding our ability to keep up and modify our own understanding and behavior. And so how do we actively train ourselves to be more adaptable, and how do we use tools to allow us to manage this information overload? And so artificial intelligence offers some opportunities for us, and there are likely some folks on the call who are more expert than I. I will offer these definitions that are used by the AMA team that is invested in monitoring AI. We have a unit that watches, it's basically an environmental intelligence team that watches from a variety of perspectives. So social media posting, entrepreneurial investment, and venture capital investments, as well as the traditional literature and things that we would all look at. And so much of what I'm sharing in this section is the work of that team. But essentially, as many of you are aware, the idea is that rather than rote computer programming, the computer can be trained and learn to do certain tasks fairly independently. So this is a big change in how we think about computing science. It's not new, as you know, it's been around for quite a long time, but the technology is now getting so sophisticated, and the hardware to enable the technology has advanced enough that we're seeing it permeate much more in our day-to-day. And so there are a lot of terms that you see bantered about. And so this shows sort of the relationship of how things are tucked into each other. But you'll hear natural language processing. That's obviously a big part behind ChatGPT that everyone's so excited about. Computer vision, machine learning, artificial intelligence, deep learning. All of these offer us some opportunities and some challenges that we need to unpack. One of the other things that's important to talk about is that there's a notion that this can evolve on its own. And that's the part that is honestly less applied in reality, but gets a lot of attention from all of us because it's a bit unsettling. And the majority of models are trained and then locked to some degree, in which case then they're applied in a much more controlled fashion. But as you're aware, there are these algorithms that can continuously learn and adapt as more and more data come in. And that's where it gets a bit nebulous for us as physicians to understand, how much can I rely on this? This thing is changing on its own. How does that fit into my work? And you're all seeing a proliferation of the tools. A lot of them are fantastic, and a lot of remote monitoring. Those of you involved in primary care are probably being inundated with extra data from your patients and trying to figure out, how do I incorporate this report of someone's exercise background or their heart rate or their blood pressure measurements over time. And so there's positive use to that, but we need to learn how to incorporate all this information and apply it to the care. But this is a really important slide that helps us think through why it's really important that we lean on these tools to some degree. So Bill Stead was a colleague of mine at Vanderbilt and one of the early thought leaders in this space, and essentially talked about the fact that the human mind can really only juggle about 5 factors in any given decision. And you may note this yourself, that if it's something's more complicated than that, you're going to find yourself with a writing pad or a whiteboard or some digital form of that, really mapping things out, because it starts to get a little too complex if you're dealing with more than 5 or 6, 7 factors at a time. And now with all of the data that we have, both the rapidly expanding medical literature, but also these data sources coming at us, it's just overwhelming. And so AI can help to expand our capacity. And at the AMA, we really like this term augmented intelligence. So rather than artificial, which implies that the computer will take over our job and the thinking, it's really, how do we use these tools to augment what we as the human bring to the care of the patient? And so really thinking about the assistive role and what that means for us in terms of improving our workflows. But then it becomes this question, if this thing evolves and changes and can learn on its own, is it like a traditional technology that we've learned, any new tool? As a surgeon, I went through training when laparoscopy was starting, and so started with an open operations and then learned how to use laparoscopic techniques. This is different because it feels almost like I could be holding the instrument in my hand and it would morph in the middle of the operation, right? That these things evolve and change. And so is it a little more like a teammate? Part of what we're trying to understand is our relationship with these tools. If you are interested more about the direct application of AI to healthcare delivery, I'll refer you to this first document from the National Academy. So this is the promise and the peril document, and it's very extensive. It talks a lot about applications across multiple clinical settings, as well as some of the concerns and issues. And I always like to remind people, we tend to think of this as something that's penetrating primarily in radiology or pathology, imaging-based fields, certainly in oncology with all the genetic elements of it. But there's applications in primary care as well. And so just Chris Sinsky, who's one of our advocates for practice sustainability, wrote this paper about the potential for artificial intelligence to improve the workflow of the primary care physician. And it's a really nice piece if you're curious and you happen to be from that background. So folks can put things in the chat if you know that you're using AI tools in your facility or in your practice. Do you have a facility that's using like a sepsis predictive model or anything like that? So welcome anyone to put in the chat how you already see this penetrating your personal practice. AI Scribe, so fantastic. So for those who aren't familiar with AI Scribe programs, this is what we're talking about with trying to offload some of the documentation. The technology is pretty fantastic in which it can listen in to your encounter with the patient and actually can put content into the correct segments of the note. So it's not just a verbatim transcript, which is not very useful, but can actually structure, knows what goes in HPI, past medical history, knows what's referring to upcoming orders that you need. And so that's fantastic. So I'm seeing a lot of administrative opportunities popping into the chat. So you're seeing that help, hopefully, your system, and that will get more and more advanced. And then a little bit of activity around actual diagnosis and care delivery. But right now, the administrative piece is a great place to get started as we improve our understanding of the technology and how it applies across patient populations. So just to kind of wrap up this section and some more of an introduction, this is the report from the environmental study that there is a lot of hype, and sometimes the hype runs ahead of the actual penetration. But now we are at a point that you're seeing it really come in. And often as physician leaders in your health systems, you'll be asked to evaluate. We're thinking about this new tool, even if it's for phone triage. You're often on those committees where someone from the informatics side of your organization says, we've been approached with this product, what do you think? And so making sure our physicians have enough understanding to participate meaningfully in those conversations is critical. We all missed the boat on electronic health records. We didn't have enough physicians trained to critically appraise that early in its development. And so now we are suffering the pain that was developed for billing. It was not developed for care of patients. And so if we want to avoid that same disconnect as AI evolves, it's really critical that we at least understand this enough to ask the questions. We don't have to build the algorithms, but we should be ready to ask the questions. And so there's a lot of activity happening, and this is what AMA is doing to help keep up for you. And I just drop in the chat our landing page, that if you want to follow that intermittently, it's regularly updated with AMA activity to support you in this space. Has links to a lot of learning materials if you want to learn more for your own practice. So now to flip more to the educational side of things, how do we provide training? We often start with med school because it's a captive audience, but we need training in practicing physicians, right? So how across the continuum can we provide training, and what should we be teaching at this time? And I want to show you this from two different lenses, because physicians need training in how to use AI to deliver care. But there's also a really exciting component around this of using AI to better improve the efficiency of your own continuing education and the training of our junior colleagues. So we'll start first with what training do we need to deliver care? And I've just listed here some of the references that this content is based on. You'll see that a lot of it's still framed as questions, asking ourselves the right questions as opposed to specific learning objectives per se. And the other thing to bear in mind is that this is all evolving so quickly that we have to figure out what are the core domains for everyone that we all need a foundation in, and what things will vary by your discipline. Certainly the clinical applications will vary by discipline, and certain specialties will use this more than others. And there will be a small group who really make this their focus and will dive in, and this will be their area of expertise, and they'll be leaders. But we really want to think about what do all of us need at this time, and then also acknowledge that it's all going to change. Everything is evolving so quickly, as you have seen with these evolving, and the excitement around ChatGPT and how quickly it has advanced. Our educational objectives will probably become more and more sophisticated over time. But this is a great starting point to consider. So I've kind of clustered the questions I have had as I speak to experts into these domains about what are the foundational understandings of AI? How does it affect reasoning and data? What are the relational challenges between the physician, AI, and the patient? What are some of the ethical and accountability concerns? And what is some of the leadership and oversight issues? And so the foundations are what we've talked a little bit about so far. Just what is this? How does it work? How is it different than other technology that we've had? Is it a tool? Is it actually going to be a partner with us? How is it being incorporated? How fast is it coming? And this is where I am trying to raise the alarm of we need to be training for this urgently, because it's here. It's not in the future anymore. It's now. So this is one of the things we glanced on, but why do we need AI? We've talked about that the amount of data we have is exceeding our capability to process that data. But it's also an opportunity for us to recognize some of the pitfalls in human reasoning. And so as you hear concerns about AI and some of the mistakes and the hallucinations that you hear about, well, we've done that too. And so this is a great moment for us to elevate to our learners in particular, but also remind those of us in practice to be thoughtful about our own metacognition. Are we critically appraising the information being put in front of us? Or are we looking for the quick answers, which in this very busy pace of care is only natural to have that happen? So how do we make sure that the information being put in front of us is applicable to the patient in front of us? What are some of our common patterns of error and bias in our own thinking? And then really helping ourselves think through different aspects of reasoning and what can the computer do well, and what can the machine not do that we as humans do well, and challenging ourselves to really focus on enhancing our abilities in the areas that we are exceptionally good at, and that would be the relational aspects, the empathy, the interactions, and maybe amplifying our own strengths there and relinquishing some of the other parts to the machine learning and technology if that's appropriate. And then this is a really important point in terms of remembering that AI is trained on data sets. We create the data sets. Every time you're in that EHR at night, after you've tucked everybody in and you've fed everyone and you're cutting and pasting and trying to get through your list, we need to be careful now about our documentation more than ever, because it's not just that patient, but now that data is being used at scale. And so being mindful to avoid the shortcuts and to be careful about our documentation, be as thorough as we can, is going to be important for us as practitioners. The relationship is really intriguing to me. You know, everyone knows colleagues who will yell at their computer or slam the keyboard down when it's not doing what they want. That person will struggle in the future. So helping to think through what are the attributes of the physician that enable us to really ultimately benefit from this technology? And is it a little different from what we've traditionally viewed? You know, we tend to think of computer scientists as people who maybe don't have the relational skills, right? That's very stereotypical, but now we need to combine these things, right? We need to be able to manage both data and the person in front of us. And so that's a challenge for us to really think about, do we have the right orientation and skill sets to react with this? And we have a very traditional doctor-patient dyad that has expanded to the team patient triad, but now we're incorporating the information as well and the technology. And you will probably increasingly have on healthcare teams information specialists that would help with that part. Ethics is a major area of concern. Many of you have heard risks around bias. You know, there's two sides to this. If there is embedded bias, which there is in our data systems, that could get amplified through these processes. On the flip side, using data at scale helps us identify bias that we might be blind to as humans. So again, something we need to work with to ensure that we get the optimal outcome. Max does not like bias. If you hear my dog barking in the background a little bit. And so we think that there's obviously great opportunity to drive value in using these big data sets, but at the same time, we have to monitor privacy and data security, et cetera. And then reminding ourselves, you know, what is our role? We always pride ourselves on being ultimately accountable for the outcomes of our patients. As we rely on these tools, how do we navigate that? That seems a little bit intimidating to us, that we are depending on something that we don't quite fully understand. And so as these models are being brought into your system, again, asking those questions on how that model was developed and how it is monitored for its own performance is really critical as physicians. And there are techniques to do that. You just need to make sure that you're asking your vendors that they are doing that and that you're aware of it. And then this notion of leadership we've talked about, it's really critical that we are involved in the design, but also at your local institutions, the implementation. We are always advocates for the patient. And so we should really step up to make sure that as these things are introduced, mostly by entrepreneurs, that we really are thinking about, is this to serve the best interests of the patients? And so again, who's in these roles to decide whether to bring an application into the workflow and what questions should we ask? This notion of algorithmic vigilance and making sure that these applications are working the way they are intended to do is important. So that was a big flurry, and we'll have a chance to have some conversation around it. But I do want to share a little bit before we go into Q&A, some of the excitement around using AI to improve our process of education for all of us across the continuum. So I have a few examples at different levels of the continuum that illustrate this, just to get the juices flowing. So we at the AMA are going to be investing heavily in this notion of precision education. I think all of us have suffered to various degrees in the educational system. We know that there are points in time where it's quite dehumanizing, that the overall package doesn't fit each individual well. It doesn't often recognize what you as an individual bring to any given setting of learning, particularly early in your training, but all throughout your career. And so we really want to leverage technology to help everyone get the right education at the right time and have an advanced opportunity for personalization of the education process. There's obviously a lot of excitement about the potential of augmented reality and virtual reality as educational tools. More and more schools are moving away from traditional cadaveric dissection to using these 3D models and computer science that actually if you haven't seen them at a meeting, I would encourage you to go. If you see it, go play with it. It's really pretty fascinating. And as a surgeon who obviously cares a lot about technique, I think that this is fine for the vast majority of physicians who won't ever need those dissection skills. You can honestly get a really good 3D orientation through some of this technology. And then maybe the cadaveric dissection makes sense for a smaller subset of learners who will really use those technical skills in a different way. So this is a really fun example from my son's college. He went to Georgia Tech, and they did a very interesting experiment. So they were moving some of their computer science programs to these massive online courses, so the MOOCs. And they knew that with that many students, they would struggle to have enough teaching assistants to be responsive, especially since the learners are all over the globe. And so time zones and all these other challenges were in place. And so they created an AI teaching assistant. They trained this AI algorithm based on all the questions that students had been submitting through an online portal to the live human teaching assistants. And they weren't very subtle. They named her Jill Watson, but of course, in an online course, people don't know any difference between Jill Watson and all the other TAs. And so not only was Jill elected the best teaching assistant, highly responsive, any time of night, answers my questions, just really engaged TA, wonderful teacher. She actually got asked out on a date by one of the students. So it was a pretty remarkable success. And the students didn't realize that it was an AI algorithm, despite the fact that they were in an AI computer course, a machine learning course. And so of course they disclosed it to the students mid-semester and made them aware of it as a teaching opportunity. It's a really funny story. They have a lot of detail about the potential risks of it as well, and some of the places in which Jill went wrong. But this was a very early experiment in using these tools to offset the burden of the educator. When I was at Vanderbilt, we implemented competency-based medical education, which is really this notion of using the same metrics of development across the entirety of the curriculum. And so thinking about communication skills in this example, that you would want to see in the healthcare system in the setting of delivering care, pulling those into the classroom setting and team-based activities that they were doing. So using the same language across allows you to put together this kind of dashboard of development. And at first, this looks like a scatter plot to you. I'm sure it does, because it's different settings and different assessors. And so there's a lot of noise in the system, but you can see that over time that those ratings are concentrating. They're becoming more consistent regardless of the setting or the assessor. This is where AI can start to predict when someone has attained competency. And so when you see that tightening of the curve, you can tell the learner, you've gotten where you need to be for this. Let's focus your attention on this other competency where you haven't hit that level yet. And so having predictive analytics to process very messy data from the clinical environment might allow us to embrace that messiness and use it in a way that allows the learner to really know where they stand. At the level of residents, I won't walk through this. It's a very complicated slide, but one of the challenges for residents is knowing who contributed what to the care of a patient. And so this is a very elaborate algorithm that is able to tell from chart activity in the EHR who's really the trainee that's most involved in the care of this patient, so that they can be paired with the outcomes of that patient. And so looking at clinical outcomes and creating a dashboard that the trainee can see themselves in and doesn't say, well, that's not me, that's the team, that they actually know, now this has been called out to the ones that you really are driving. That allows us to use our performance data to really improve how we grow. And then even the ABMS is very excited to partner with us in thinking about, for you, those in practice, how can we make continuing professional development and maintenance of certification a little more streamlined, a little more relevant to your day-to-day. And there's potential, a tremendous opportunity of capturing data from EHRs to facilitate that process and improve the alignment of what educational materials are being put in front of you with what your actual needs are based on your panel of patients. And so at the AMA, we have an AI algorithm that we've developed that does just that. It can look at your entire panel of patients for an upcoming week's clinic, as one example, and gather deep data from those charts about the patients and use that to create a query to PubMed that's much more refined or much more detailed than you would ever do yourself. And then that can lift to you each week. You may want to see these papers. This is not a one-to-one clinical decision support. You don't get a paper that might help you with Mrs. Jones. This is saying, based on your practice and your desire to continue your professional development, these are the articles that may be most relevant to you. And it's a very sophisticated thing that will put, if it's a patient issue that you see all the time, it's going to give you more recent cutting edge literature. If it's something that you rarely see, it's going to refer you to a secondary resource, something that's more of a summary or review. So for those who are involved in teaching in any way, we have a paper out there that think about how you might start to incorporate this for your learners. That's with the National Academy that I referred to at the beginning. And that's all from my formal comments. Hopefully we have some time for some Q&A and some discussion with you.
Well, thank you so much, Dr. Lomis. As a former engineer, also from Georgia Tech, I find this to be very fascinating.
That's great.
Yeah, I graduated in 92, and it doesn't surprise me that they're leading in this area. So excellent. Any questions for Dr. Lomis? Comments? Any thoughts?
Dr. Marshall, we did have a few comments in chat. And so one, I'm working from the bottom up. Where are the ethicists in all of this?
So as you all know, we have an entire unit at the AMA around medical ethics, and they're looking at both the ethical and legal issues at the AMA, and they're partnering together because there are the ethical concerns and then there's legal. And as we all know, in real practice, ethical usually trumps legal. In this area, we do know, though, need some guidelines and some regulatory oversight of these technologies as they're being designed. So there's active conversations around all of this. And of course, then there's the bigger ethical, philosophical question of what it means to be human versus what these machine learning algorithms will evolve to. And so there's some interesting conversations around that at all as well. But there's definitely a lot of activity in the medical ethics space regarding this.
Dr. Rockower.
Thank you. I just want to comment. Some of you may have seen my review of a recent book by Dr. Jen Lycette, Lycette, called "The Algorithm Will See You Now," which is a semi-fictional book about future algorithms taking care of patients and giving you the idea of how the data sets work and what happens when the data sets are corrupted. It's really a fascinating thought. So I certainly would expect everybody to look it up. I don't get any money for pitching her book. She has another one coming out called "The Committee Will Kill You Now." So you see where she's coming from, but I'll put it into the chat so you can look at it.
Thanks for that, Dr. Rockower.
There were also a couple of comments about legal accountability, and Dr. Lomis just touched on that a little bit. But I love Dr. Rockower's quote, "The computer made me do it." And so does that stand up in a court of law?
Yeah, and this is where the AMA is actually advocating for regulatory oversight, which is an interesting position to be in because in general, we prefer, as you know, as a physician to be as a profession to be self-regulating. But we actually submitted formal in multiple settings, but one example was to the FDA, formal request for more specific oversight of the development of these technologies and clarification as a tool is used of how that interacts with what the physician is held accountable for in the tool. And for the most part, it is like other technology that we have all been trained on at various stages of our career and thinking about what foundation do we need in order to use these tools appropriately. But there is a limit as everyone's sort of sensing that if this is different and it is less about a static tool, then how are we going to be accountable for that? We are in the process of creating some online modules for training in AI. Again, our target was medical students, but it will be widely applicable to all of us who need foundations. And it's been very helpful for me. Honestly, most of the modules we develop, when I help to review them, I know all the content and I go through them very quickly. I've had to study this one. These are hard. So they're detailed enough for us as physicians. And there's a great example that walks you through how algorithms are developed, not in painful computer detail, but this notion of What data is it founded upon? What might be some of the risks because of that data? What are some of the risks in terms of the algorithm and keeping up with changing pace of the data? So those kinds of trainings will help you ask those right questions before you use a tool, so that hopefully you can, understand what you're dealing with and stay out of trouble in the first place. Because one of the concerns is that physicians will unwittingly apply tools to the wrong patient population because they haven't asked the right question of how the tool was developed in the first place. And so we are creating these modules that will give you that foundation as a start. And then, as I said, on the advocacy side of things, the AMA is developing a great deal of policy and recommendations.
Excellent. Any more questions for Dr. Lomis? All righty. Well, thank you so much again for joining, and thank you for this really intriguing conversation and presentation today. We will, can we contact you if we have any additional questions? Would you mind?
Certainly, and I dropped that link in the chat earlier, and I'll do it again. I would encourage you to follow this page. As I
Yeah.
said, peek in it because it's updated when those modules go live, which will, some of them will be before the end of the year, and some will come out in January. That will get posted on there, and so that's a great place to just touch base every once in a while to keep up with what the AMA is doing on your behalf in this space.
Excellent. Thank you so much again for joining.
Thank you for all you do.
Thank you.
Thank you.
All right. Next, we want to spend just a few more minutes talking about the initiatives that we've put forth to the House of Delegates. So if you're a delegate or interested in the initiatives, please feel free to stay on this call for our caucus of delegates. If not, if you choose to leave now, we thank you for joining and we'll see you next time. But we hope that most of you will stay and hear what we're putting forward to the House of Delegates.